Thank you, Christine. I think you also have raised many questions that resonate with the other panelists. I couldn't help thinking as you were commenting on sort of the debrief on something that was labeled as sepsis, trying to understand what the clinicians were thinking at the time. And that reminds me of the first time I heard Foster sitting in New York working with frontline clinicians that were getting ready to try to implement Rory's regulations. And he was very much thinking about the interface between the top-down government standard and how that actually was going to resonate one patient at a time at the coalface. And so with that, Foster, over to you. We would love to hear your reflections from your time at New York on the role of government in promoting excellence in diagnosis.
Well, thank you, Derek. And thank you to all the speakers and all the participants today. Not only was it a great day, but I realized that a lot of the contributions, both in terms of the work and the individuals that took part in this, really markedly and specifically contributed to whatever the successes are that we had in New York with this initiative. We relied on, a number of the people on this panel, you know who you are, and, some of the work that was described today. All the warts and all the problems I'll attribute to myself, but you guys get a lot of the credit, as well as the advocacy organizations that were mentioned earlier that played such a huge role in shaping and informing public policy. And I'll talk a little bit more about what that role and so on. I want to, second everybody's comments. I think that the comments that Laura made about collaboration and connecting the dots of all the different activities really resonated for me today in terms of trying to visualize as a model for success, whether it's a funding model or a success for patients, the ability to put together this tremendous advances in diagnostics and understanding of immune response with machine learning and use of data, both structured and unstructured data, along with a great chain of activity on quality improvement and culture change and behavior change for clinicians and systems. So I was really heartened in the last sessions that have tried to talk about sort of how to integrate what we heard in the morning on the science and those advances with QI efforts and also with system and change management. For me, going to the question about success, the litmus test for me about diagnostics and diagnostic excellence really relates to or is formed by the degree to which it specifically improves outcomes for patients. And I would say not only patients, but for populations, and not just thinking about communities or states or the nation, but across the diverse populations of people that are impacted by sepsis. I think the second is demonstrably showing in diagnostic work and diagnostic excellence that care decisions are impacted, as well as potentially prognostication, hopefully both, but one or the other. To me, it's part of the litmus test to say that whatever it is we've done, whatever new testing or approaches we have, that we've really made a difference. And then the last, Christine talked about this in a very pointed way, that what we do actually reduces errors and harm and decreases the risks to patients. So to me, part of this collaboration, part of this vision of the future is better understanding the impact of changes and development and evolution in diagnostic excellence and how it impacts specifically those things. And that has some implications for what needs to be measured or evaluated or followed as different approaches to diagnostic excellence are being advanced. I think the conversations today really made me think a lot about something I had not thought very much about and has not really been measured, which is specifically and directly, what is the contribution of diagnostic excellence to the variation in performance in outcomes or process measures that have been talked about today? And the reason I think that that's so critically important is, obviously it helps us understand what role it plays relative to other factors, including interventions and access to care. but I think it also relates critically to the issue of disparities, which was talked about so clearly in terms of outcomes in sepsis, and a better understanding of the ways in which diagnostic excellence contributes to those outcomes, those disparate outcomes, I think gives us better clues about where to go with this. Some people have talked about this using different words. It's also struck me that part of the answer of success in going forward is dealing with a very fundamental balance and tension in this work, which is if in fact the diagnostic process for sepsis increases in complexity, and I think we heard a lot about the complexity today, good complexity, but it happens in the face of a time-sensitive condition that in which patients present in many contexts, and not just in centers of specialization. And as was pointed out by Dr. Liu, not only in the context of even healthcare systems. So how do we deal with that challenge of thinking about the distribution of patients, the types of patients that are affected by sepsis, where they present in and out of the healthcare system, along with and coupled with this increasing technical complexity in terms of markers, machine learning, use of structured data, and so on, I think is a real interesting challenge going forward. I'll just end with this: picking up on a piece that struck me about the issue of measurement and what we measure currently, and what we don't measure, related to diagnostic excellence. And so, specifically, I think that Jeremy alluded to some potential, maybe good enough places to start thinking about how we balance what we're doing in terms of evaluating process care for patients with and outcome measures of mortality with issues about overdiagnosis, underdiagnosis, and late diagnosis, which I think would really inform a lot of the quality improvement activities. I hope folks will correct me that this has been a part of some initiatives, whether it's in Michigan or at Kaiser and elsewhere. But I would confess that in New York, we focused on the process measures, we focused on mortality, but really did not look at in any broad way this issue about under recognition and over definition, over identification. And as Jeremy pointed out, there are ways in which any quality metric is going to potentially create some distortions that need to be looked at, or some opportunities to better understand how early diagnosis and excellent diagnosis, if you will, contributes to the outcome. So I'll stop there and look forward to questions and dialogue.